Welcome to the Mercy Care Arizona Complete Care Regional Behavioral Health Agreement ACC-RBHA expansion webinar hosted by the Mercy Care Network Management Team. Today, we're going to talk a little bit about Mercy Care. We're going to give you some information on non-title and crisis and state-only enrollments, crisis services, utilization management, claims, language access services, an overview of our grants, some information from network management on our provider services profile, information on the ACC-RBHA health homes in Gila and Pinal, information on integrated care management, the Office of Individual and Family Affairs, some reminders about COE and COT, QOC information specifically for seclusion and restraint, our member impact, and then we're going to open it up to questions for you guys. And with that, I'm going to pass it over to Brad Hargans, who's going to give us an overview of Mercy Care.
Good morning, everyone. A little background in regards to Mercy Care. I know many of you we already have relationships with and are partnering with. But Mercy Care is a not-for-profit. We've been in Arizona since 1985. We have local sponsors, Dignity Health and Ascension. And we administer multiple lines of business across the state of Arizona that you might have either currently working with us as part of, or will be soon. So we do the ACC plan. We have an All-Tex plan. We have one of the two plans that administered benefits for the DDD population, DCF-CHP. We're also currently the RBHA for the Central Region, and that's why we're all here. We're going to talk about the expansion into Gila and Pinal counties. As noted, that we're moving into as part of the RBHA award that occurred in November. The Central Region is now going to include the counties of Gila and Pinal. Mercy Care has been the RBHA for the Central Region since 2014. We're looking forward to this opportunity to partner and to grow into Gila and Pinal County. So the good news is, if you do work with us today, not much is going to change. This is going to be an overview in regards to, as Tara walked through, a lot of information. But if you're doing work with us today, not much is changing. If you're new, welcome. And a lot of information is going to come your way. This deck will be made available at the end with some, and it contains critical information that I would highly recommend bookmarking. Maricopa County is currently being administered by Mercy Care, and as of 10/1 of this year, we will begin administering benefits for the RBHA population in Gila and Pinal County. This is for the RBHA population. This is integrated benefits, physical and behavioral health services for SMI designation, and this would also include administration of crisis services and grant services. And now, without further ado, we will discuss non-title enrollments. Dana?
Thank you so much, Brad. I'm going to go over non-title enrollment. Non-title enrollment is intended for persons without a Medicaid benefit, but are otherwise eligible for publicly funded behavioral health services. The link that you see here is where you can go to find additional information, as well as do the enrollment for this. So for non-title enrollment, the transaction can be completed in our secure web portal. And non-title enrollment remains open unless the member's transaction to Medicaid or is determined inactive by the health plan as determined by claims activity. Crisis and state-only membership. For crisis and state-only membership, Mercy Care is responsible for administering limited crisis and state-only services for persons having behavioral health coverage through an ACC or another RBHA. To process claims for these individuals, Mercy Care RBHA must have enrollment information for the member. Providers rendering crisis and or state-only services to persons having behavioral health coverage through an ACC or another RBHA share information with Mercy Care. Mercy Care compiles the member's detail and sends it to Access in a daily file. Access processes the records and returns enrollment detail in an 834 file. Once Mercy Care has this information, crisis and state-only services will be adjudicated. And we do provide a link below to provide some additional information and so forth. The transaction for state and crisis services, the transaction can be completed in our secure web portal. The crisis span is open for 3 days, and then the state span is open for 30 days. Next slide. And I'll go ahead and pass it over to Shelley Curran.
Hello, good morning. Okay, so we're going to talk about crisis services. The crisis services are not changing. We still have the same crisis system in Arizona that we've had, which includes crisis phones, mobile teams, and crisis facilities. One of the things that is going to be changing, which is good, is that now the central region includes Maricopa and Pinal and Gila. It's all going to be part of one crisis system. So let's say you're working in Pinal County and you have a child who you think needs to be referred for observation services, for crisis observation services. We actually have that here in Maricopa County. It's new, but we have it here now. So we're not looking at county lines anymore in regards to crisis services. So services that are available in Maricopa are also available to Pinal and Gila in regards to those facilities, in regards to mobile teams. So we just want to make sure that folks understand that we currently have a very strong crisis system in Gila with their mobile teams and in Pinal with their mobile teams. And so now Solari is going to be the statewide crisis phone vendor, and they're going to be looping in the mobile team dispatch from across the state. So a little bit of change in regards to what the function is. I think it's actually making more services available to the members that are in Pinal and Gila and just those communities in general. So as far as change, still the same system, but now all 3 counties are included in the central region. I think that's all we had for crisis. Yep. Thank you.
Thank you, Shelley. And next we're going to have Caroline talk about utilization management information.
Good morning. Just some information about our UM team. So our UM team works Monday through Friday from 8 till 5. After hours, we do have a call tree through member services where we can get a message for urgent discharge planning needs. And there's also a number on the screen for our physical health team for after hours. We have a number of fax numbers that our team uses. The bottom one speaks specifically to the behavioral health. And that's where you can send admission face sheets, medical records, and the census for us. Next slide. So our concurrent reviewers and BH clinicians, they review each inpatient admission within 1 business day of notification. Our subsequent reviews are based on member-specific condition and the medical necessity criteria. We focus really strongly on discharge planning, and that starts as part of our initial review and continues throughout the entire hospitalization. Our reviewers work really closely with the hospital case managers, social workers, and discharge planners, and they should be coordinating or being notified of any barriers to discharge so that they can assist with that coordination of care. Next slide. We do not require prior auth for an emergency admission. However, we do require a face sheet to be sent in within 1 calendar day of the admission, and the fax number is again provided there for you. One difference to note between our physical health and our behavioral health teams is that all of our behavioral health initial and concurrent reviews are completed telephonically. There are some non-emergency services that do require prior authorization, and we do list those on the screen. Next slide. Finally, some information about our out-of-home levels of care. Mercy Care does require prior authorization and concurrent review on all behavioral health residential facility admissions and adult behavioral health therapeutic home levels of care. The outpatient team is required to submit a prior auth request, including all supporting documentation. We have provided a link to the form here, and that is also available on the website. Once prior auth is approved, our referral coordinator will match up the member's needs with our in-network providers, and they will send an email to the outpatient provider notifying them of which facilities they should send referral packets to. Lastly, one thing to note about the prior auth approval process is that authorization is valid for a 60-day period. And if after that time the request is still needed, then we would require additional documentation to extend that authorization. And I will pass it to claims.
Thank you. I am going to quickly skip over claims, and we will come back to that topic. So next up, we have Donna McHenry, who's going to go over our language access services.
Good morning, everyone. My name is Donna McHenry. I'm the Cultural Sensitivity Administrator, and I just wanted to go over quickly an overview of how to navigate our language services. If for whatever reason you should have additional questions or need additional support, you can reach out to our office, and I'm happy to come and present to your team and answer any questions to help them navigate and support our members. Next slide, please. So here you have an overview in which Mercy Care offers 3 components to our language access services. The first component is qualified bilingual staff. These are the staff members who go through the process of becoming proficient in another language other than English to deliver a covered service in that language. Once a staff member has been determined to be proficient in that language, they're able to build that covered service in addition to the T1013 code in order to get credit for that service being delivered in another language. The next component that we offer is our on-demand services. We have 2 areas that we cover here. One is over the phone for all spoken languages, and that information is available on Mercy Care's website so that you can have access to an interpreter 24 hours a day, 7 days a week, 365 days of a year. To parallel this process for our spoken languages, Mercy Care has taken on the video remote interpreting. This service is only available for American Sign Language. And this is to, again, ensure that our members and their family members who are deaf and hard of hearing have access to interpreters 24 hours a day, 7 days a week. In order to access this feature, providers will need to have prior setup. So if you're interested in having access to VRI, you would need to coordinate this with my office, with the Cultural Competency Office, and we will ensure that you have a password and credentials so that your team can utilize this service. The third component is our scheduling service. This is where providers will contact Mercy Care's member services to provide or to schedule appointments either face-to-face, over the phone, or through video, which is our scheduled virtual interpreting. This is different from VRI. VRI is, again, only for American Sign Language, and this is where services are delivered when the provider and the member are in the same location, and the interpreter will come on and join the appointment through a computer, the cell phone, or a tablet. They will do this remotely. Versus when you're asking for a video appointment through our scheduling services, all participants are meeting virtually. And so if you're needing that service, you will contact Mercy Care's member services to arrange this appointment. Next slide, please. So this feature is, or this slide is pertaining to our scheduled services. These are pre-scheduled interpretation services for our members. You can contact Mercy Care with regards to the benefit in which the member is aligned. and they will take your information and they will submit it to our vendors. Member Services is not able to schedule appointments beyond 30 days. Please keep that in mind as you're requesting interpretation. We also ask that you, when requesting, making requests for interpretation that's over 3 hours, that you ensure that there is clinical justification for such. Next slide. So what you have on the screen is Mercy Care's process. This is basically what everyone will do in order to schedule an appointment for an interpreter to come out for an appointment. Providers will contact Mercy Care Member Services to schedule the appointment. Once that happens, the information is entered into our scheduling portal called the Interact. Once that occurs, a notification will be sent to the requester to let them know that we have received your request for interpretation. At the same time, that information is sent to our vendors to let them know that we have appointments available for them to fulfill. When a vendor accepts to fulfill an appointment, a notification is sent to the provider requester so that they know that request has been fulfilled. If for whatever reason a vendor is unable to accept an appointment, a notification is sent to the requester provider to let them know that they will have to have their request fulfilled through Mercy Care's on-demand services. Please keep in mind that any scheduled interpretation delivered outside of this process will not be supported by Mercy Care. If you submit a request for interpretation, if there's any modifications, you would do that through our member services, not with the vendor. If you have more questions regarding this process, again, I'm happy to support you and your team in coming out to make a special presentation and answer any questions you have. Next slide, please. So things to keep in mind as you're submitting your request is to confirm the clinical need. This is that it's aligned to the member's service plan, that the member is eligible for Mercy Care services. You do that by ensuring that there's eligibility and the access ID is included in your request. Things to keep in mind is that please include all relevant information pertaining to the appointment. If the appointment is happening through video, we ask that you include the Zoom link or the WebEx link. If your agency has requirements with regards to COVID or other precautions that an interpreter is needing to know, please include that in your request as well. The other thing to keep in mind is that interpretation only happens when it's delivered with a covered service and delivered in the presence of the clinical team. So absent of those things, interpretation is not available. Next slide.
Thank you, Donna. That's the last slide I have for you
Thank
for
you.
language access services. Thank you so much. If you guys have any questions, feel free to use our chat and Q&A. And next, we are going to have David give us an overview of claims.
Good morning, everybody. My name is David Vargas. I'm Director of Operations for Mercy Care, and today I'll be, as Tara mentioned, I'll be discussing claims processes and everything tied to that, or a lot that's tied to that. So just to kind of give an overview of some of the specific items of what we work to do, we actually maintain a very good record of timeliness for claims processing. We don't anticipate that there's going to be any kind of changes for that. This we are very much seeing as just an expansion of our current businesses, which is actually a good thing because we have a very good foothold as far as everything we have currently set up. Our current timeliness metrics are at approximately 98.47. That's a very specific approximation. And that does fluctuate from month to month, obviously, but then our 90-day processing timelines are at about 99.47%. So we get most of our claims processed within 30 days, and then even more of those within the 90 days. A lot of what we see that spills over just requires some specific work and some specific management around those. The average time to processing all claims is about 10 days. Again, that can go up or down in a month, but it usually doesn't fluctuate by more than a day or so. So if you do start to see claims going beyond that, or if they're starting to approach the 30 days and you have questions, we can always work through provider relations to identify if there's any particular issues that need to be resolved. Next slide. Excuse me, we recognize that Mercy Care and most commercial payers do not cover behavioral health CPT codes that begin with the H, S, and T codes. We do not require an EOB submitted for those that show the Medicare or other insurance denial. We will override the COB editing that we have programmed into our systems when those particular codes are the only services submitted. So if it's a non-covered Medicare, or usually we go by the Medicare standard. So if it's a non-covered Medicare service and that's all that appears on those claims, all that we will do is go through and we will override those COB edits. We will pay those as primary. So you should expect to be able to do that, to submit those directly to us without having to go through Medicare for those. So if there is something that gets paid by the other payer, we would want to see that explanation of benefits, however. So sometimes they do cover those. So that can be handled on a back-end process. If you have submitted it to us, we've paid as primary, and then you submitted it to the other insurance and they've paid it, you can send in a refund to us. You can send in a corrected claim with the explanation of benefits attached, and then we will go through and we will coordinate benefits on those. We can receive claims that have been coordinated with other insurance via EDI. You would just need to submit those through your standard EDI vendor process. Most of the clearinghouses, actually I should say all of the clearinghouses, have a process for you to submit those using EDI loops and segments. So there shouldn't be an issue if you do have that information and you want to work with your clearinghouse to get that submitted. You are not required to submit them on paper with the EOB attached, but if that's frankly the only way that you can go about that, we will obviously accept those through that process. But it is much faster and easier for us to accept those if you submit them electronically using the EDI information and the appropriate loops and segments for the COB information. Next slide. So to discuss about the state-only codes, there are a set of services that are classified by Access as state-only. We do give a very specific descriptions of what those are. They're the 97810 through 97814 for acupuncture, H0043 for supported housing, and H0046 for mental health services, for the healing services, the training room and board, all of those things. For those particular services, you would submit them directly to the RBHA. If the member needs, if you have to create a state-only enrollment, then you would need to go through the process of requesting that that be added. The particulars around that will be covered through others who will discuss that particular process later in this particular presentation. So just be aware that there may be a little bit more that needs to happen with those as you're trying to submit those claims for payment, because you may have to, again, request that the enrollment, the state-only enrollment, be added to our system before we can actually process and pay those services. So that's a very important step in that process that you need to make sure is being managed before those claims are submitted. Otherwise, we will deny those services, and then you'll have to go through the process of retroactively adding them. We can try to adjust the claims in that instance, but it's a little bit more cumbersome for us to do that. We have to submit projects and all sorts of other things. So just much easier if you make sure that that enrollment segment has been requested and created prior to submitting those claims for payment. Next slide, please. For the titled and non-titled crisis, the RBHAs remain responsible for the provision of behavioral health crisis services for up to 72 hours. That does not include inpatient services. And then we do give definitions of what those crisis service look like. So they're the H2011, the H2011 slash or with the HT modifier, S9484, S9485, H0031, and then additional services that may be available for the non-titled members. So this is an instance where from a claiming perspective, those would need to be flagged as emergency services so that we can understand that they're related to that crisis segment and that crisis portion of that member's care. This still does create some concerns and issues for us as the RBHA, because if a member is enrolled with both an ACC plan as well as a RBHA plan, it is possible that those can be paid by either entity in those cases because they are covered under both programs. So it's very important that if you are submitting something to the RBHA for payment, that you also do not submit that to the ACC plan, because what frequently happens with those is whichever plan gets that encounter submitted to Access first gets credit for that, and then the other plan has that denied by the state, and so we have to go through a process, a back and forth with the other plan to make sure that we can get that accepted on the encounter. It actually creates a pretty heavy administrative burden across both plans, and then on top of it, you may start seeing those claims recouped from one plan and then paid by the other, where we're trying to coordinate that behind the scenes. So it's very important that as the behavioral health providers, you try to identify specifically which of the two plans is really supposed to be paying for that service and try to just bill that one plan, whether that's the RBHA under that 72-hour crisis benefit or the ACC plan under their standard management. So anything you can do to help us make sure that that's being submitted to the correct plan and being paid under the correct plan helps to alleviate some of those administrative burdens that we have after the fact, trying to make sure that we're getting those accepted on encounters and that we've gone through all of that process. Next slide. The titled and non-titled grants, so grant funding such as substance abuse, SABG, mental health, MHBG, and substance use, SUD, remain the responsibility of the RBHA. So we will consider those services for payment based on those funding sources. Providers who qualify for the grants receive notification of the amount of money they are awarded and will continue to bill the RBHA for those services. And then grants are that payer of last resort. Typically speaking, Access or the Medicaid plan would be the payer of last resort, but for these particular grant funding sources, it is actually even beyond that particular process. So we will actually still continue to cover those through the grant funding, but those have to obviously be pre-approved. You have to have gotten the grant funding sort of set up ahead of time, and then there is the back and forth that goes with that of doing the encounter validation and making sure that everything sort of ticks and ties and that what you have submitted from a claiming perspective matches what the funding looks like from that grant funding that's been given out. So a very important process around that. Obviously, there are others who will speak to some of those items throughout this particular presentation, but they're also going to be talking about who to speak to about grant funding and those sorts of things. So just wanted to kind of touch base on this from a claiming perspective. We do actually have the process in place, but those do need to be sent to the RBHA to continue to receive the credit for those grant-related services that are being submitted. Next slide. So prepayment, so enforcement of correct coding using integrated system products and access reference files, outlier itemization reviews, including bundling, billing errors, level of care, experimental services, never events, those sorts of things. So these are the standard prepayment editing processes that you will see for pretty much any of the health plans across the state. We use all of the necessary national reviewing processes. We use correct coding. We use CPT modifier combinations from Access. We use, you name it, we use the various editing that's around that. If you run into something from a claim perspective and there's some confusion as to why an edit took place, or if you're seeing something that sort of takes place routinely, you can reach out through your provider relations staff, and we will try to work with you to kind of educate and give some additional information as to what the issues may be with those. Some of them are kind of obscure, and so we just need to make sure that we're covering them, but we very much try to make sure that on a first pass review of these claims that we are applying all of the necessary coding elements that Access and CMS would require around something like this. So it's just us trying to make sure that we are creating fewer headaches downstream by having us submit an encounter, have it be rejected, and then have to go back and recoup money. So it's just much easier to get the edits in front. So that's what you may see with those. So just be aware of those, that those things will still be enforced on your claims, even if they are classified as part of the grant funding I spoke about a moment ago, and they're going to pay, quote unquote, $0, because we still have to go through that editing process at the state level to make sure that those encounters can be accepted. So it's important to understand that even on those claims that are zero paid, that those edits can still be enforced. And so you may have something that looks like it's that denies through that process. And so we want to make sure that you're aware of that and have the information in front of you. We also do post-payment review. The biggest one that we have right now are for DRG and SOI coding. So that's going to be more for facilities. There are some additional concepts that we do have in place, but a lot of those are for things that we can't build into our claim processing system up front. So we do have to sort of do a post-payment review process to identify things that are maybe paying incorrectly. The encounter errors is one example that we do of that, where we're reviewing anything that has been pended or denied by Access on our encounters to see what we need to potentially recoup and those sorts of things. Again, we try as much as possible not to have that happen as a post-pay process, but sometimes that's really the only avenue we have to try and get those things corrected. And then the final bullet point on this for the differential adjusted payments, there are mandated, there values that will increase or decrease. Usually for the Medicaid side of things, it is just an increase, the payment that you would be looking for these. Most providers are already aware of what their DAP eligibility looks like, which providers they have in network that are eligible for that. From our perspective, anything that is tied to a clinic or those sorts of things, clinics, facilities, the additional items that I could kind of go through one by one, we do as a prospective process. So we include that DAP adjustment in the initial payment or the initial allowed amounts. If it's something like a professional services, so an MD, a DO, a physician's assistant, or a registered nurse assistant, we actually have a process where we coordinate those after the fact. So you may receive an additional check outside of our claims processing system to accommodate all of the different DAP values that may apply to an individual provider. The reason we do that is because those can actually be, a physician can be tied to multiple different pay-to records. And so those are, the physician themselves may apply for that particular increase, but we'd have to figure out where we can attach that across every single contract for that particular provider. So it's just much easier to do a retroactive review and application of that than to try to do it up front. And I think that was my last slide, but oh, nope, it is not. Addresses and payer IDs. So this is very important information. We are providing all of the various addresses to submit claims to for medical and behavioral health claims. Those would go to the MercyCare REBA claims department, and we have a new post office box. I want to make sure that attention is drawn to that. So if you already have an existing PO box that you're using, and if it is not the one that's specified here, we will request that you go ahead and correct that to the new address that you're seeing there. For this particular process, we do have the Change Healthcare EDI vendor information on the right-hand side. You can kind of see where those lie. What the, we have our payer ID is the 33628 for the REBA, so please make sure that you're using that when submitting things electronically. Back to the left, the dental still goes to Dental. Actually, those will start going to DentaQuest once we get to this October. Technically speaking, that's even going to be starting in July. So once we hit July, DentaQuest is going to be processing and paying all of our REBA dental services. So even before we get to October, that new address is going to be applying for all of our dental claims for the REBA as well. For refunds, we do have the finance department internally that those need to be sent to. So just please make sure that you're reviewing those. And these addresses are very important. So we just need to make sure that we've got all of that in front of folks to get those out there. And then I want to just kind of touch bases really quickly. I don't think we have it mentioned here, but appeals and grievances, we have a different address. It is actually our physical address here in Arizona that those need to be routed to. We're actually going to be publishing a provider notice, I believe later today or perhaps tomorrow, that sort of outlines that and really draws attention to that. The address for, it's very important that the address for those appeals and grievances be used rather than the post office box for the actual mailing of claims, because if they don't go to that physical address, they could be misrouted and there may be delays that take place with those. Whereas if you are submitting them to that physical address as indicated, then they will actually get immediately sent to our office and they get routed where they're supposed to, and we don't have nearly the same issues that we have if they're going to the post office box. I just wanted to make sure that that was a reminder that I sort of flashed on really quickly. If there's any questions around that, we can definitely answer those. That physical address is actually included on all paper remits that you have. It's available on our website. You can find that information all over the place. So, but if you have any questions about that, we are free to answer those, and we can certainly give you information as needed. Next slide. I think that's it. Thank you, everybody, and hope you have a great day.
Thank you, David. I will include that information for grievance and appeals in our follow-up email today. Thank you. And next we have Matt Joya up, who's going to talk to us about grants today.
Thanks, Tara, and thank you, David, for your review of claims. Also, thanks to our providers who were able to attend today for the overview. If you give me one moment, please. But Tara, we can go ahead and go to the next slide. Really, for most of you, I think we've been able to work closely with our partners at Health Choice and Arizona Complete to get folks comfortable and learn a little bit more about the respective grant-funded networks in each of those counties. What we wanted to do is, at bare minimum for the purposes of today, is go through and at least get you guys contacts for who these respective program leads are as we get a little bit closer to 10/1. For all intents and purposes, what we're seeing currently is just shy of around a 55% network match for our non-title SABG, MHBG, and other grant-funded providers. So for many of you, this may feel like a new opportunity, and much of the information that was actually presented earlier in regards to enrollment and some of the coverage under non-title will apply. So we'll be working with folks as we get a little bit closer to the start of the next fiscal year. We anticipate July as we start really sitting down with those providers and working in conjunction with Health Choice and Arizona Complete to correlate some meetings and get folks comfortable with the transition. We know, particularly when we think about some of the multi-year initiatives, and I know for what we covered mostly today revolved around encounterable grants. And I know that there's several of you maybe on the line that work underneath cost reimbursement grants such as SOAR or other activity that may be invoiced. So as we get a little bit closer to transition, we'll be working with you guys and sitting down to not only provide an invoicing or orientation for your organization for any cost reimbursement activity, but also getting folks comfortable with some of the nitty-gritty details that Dave and Dana were able to go over regarding claims and enrollment for our non-title populations. What you see in front of you here are the project leads in those respective funding types. We understand with these multi-year initiatives underneath SOAR and even more recently the CURSA initiatives, we know that there's a tremendous amount of sweat equity that has gone in to the approaches to get these projects off the ground, and we're going to do everything we can to ensure continuity through these projects into the future. So More information to come, but should you have any other questions in the meantime, I'm going to go ahead and drop our general grants inbox into the chat. If you guys have any questions about your unique project or your unique campaign under any of the grants, definitely let us know. We'd be interested in talking with you. And just as a general FYI, you know, some of the feedback that we'd actually received from other REBA counterparts is that select providers may be reluctant to move forward with any hiring under some of the grants as we look towards a transition. We want folks to continue to keep their foot on the gas. If you guys have got plans in order, continue to move through those, and we'll do everything we can to continue to sustain the funding around those initiatives. So we'll be working more closely with you guys as we get a little bit closer, but for all intents and purposes, that is all I have for today. But again, if you have questions, please reach out to the grants inbox and we'll be sure to address anything you guys have. But thanks. And I think we're back to networks, Tara.
Yes, thank you very much, Matt. Next, we have Jessica up, who's going to talk to us a little bit about her project, the Provider Services Profile.
Good morning, everyone. My name is Jessica Clemons. I am the Network Administrator for Mercy Care. Thank you for being here today. I'm going to talk to you a little bit about one of my passion projects. If you've met with me at any point over the last 4 years, you've probably heard me talk about it. We're going to talk about the Provider Services Profile, or the PSP, which is how I'll refer to it for the rest of this. We can go to the next slide. So what is the PSP? This is a proprietary tool that Mercy Care created to capture site-specific services that are available within our provider network. When we created this initially back in late 2017, we did so with the intent to capture behavioral health services specifically, and that's because oftentimes behavioral health provider types are not necessarily indicative of the specific services that are available within that provider type. So for instance, we might have a provider who is registered as a 77 that's delivering, SMI health home services. They could be delivering children's services. They could be a Jim-Sue outpatient clinic. So it was just hard for us to really understand what specific services were available within our network. So we created this tool. And as I mentioned, we started this with behavioral health providers. And at the time, back in 2017, it was really what we are referring to as sort of our legacy REBA providers. So there were about 250 or so that we surveyed initially. And then we expanded that as the years have passed to include any new behavioral health provider who's been added to the network. And most recently, we're expanding that to include physical health providers as well, so that we can start to capture the availability of integrated services within our physical health network. So the way that this tool was created, just a little bit of background, was we met internally for quite some time to establish what specific services we wanted to make sure were searchable for members and referring providers to help get members connected to services. And we ended up coming up with around 150 elements. So, and I'm going to show you an example of that in just a bit, but there's about 150 elements that we send out to providers and ask them to complete based on the services that are available by location. So it becomes very important to understand that this is a by location report. So if you are a provider who has 40 locations, we would need this completed for each of those locations so that we can make sure that we're getting members connected to your sites that are delivering those specific services. And then, it's also important for us to note that when we were creating this tool, we were also factoring in other forms or credentialing documents or things that you might also be completing and doing our best to avoid redundancies so that you're not having to tell us the same thing multiple times. So we can go to the next slide, please. So right now, previously the way that this information was collected was, like I said, back in 2017, we did a mass collection of our behavioral health network. And then the idea was that we were collecting it annually thereafter, as well as collecting this for our newly contracted behavioral health providers as they were joining the network. However, we are now looking at trying to survey our entire network, starting with specific specialties to get them to start submitting this to us and start capturing this information for providers beyond our behavioral health network. And so Some of you may have recently received an email from your provider or from your network relations representative, including this tool and some specific instructions on how to complete it, because what we've done is send this back out to about between 750 and 1,000 provider groups to start capturing this information, more robustly than we have previously. And then once we get this back from those providers, what we do is, we load it internally into an internal system that we use, which becomes searchable for Mercy Care employees inside of, in-home, but it also then feeds our online provider directory, which makes the content of your responses searchable for members or members' families, support groups, or, referring providers who are trying to get members connected to coverage services. When you're completing this, one of the things that I think is really important to remember is we are looking for you to only say yes that you're delivering these services at these sites if you have staff that are licensed, certified, or specifically trained to deliver the services that are outlined on that tool. So for instance, if DBT is one of the services that's listed there, you would only say yes that you offer DBT if you have a therapist who is licensed to or certified to deliver DBT therapy services, and that you would be willing and able to accept referrals for members for those services specifically. So we don't want a yes response if you have DBT-like modalities built into your programming.
I lost you, Jessica. No. I know I lost your audio, sad face. Okay, let's try it again.
How about now?
Yes.
Okay, sorry. Well, it's not a webinar if there's not a technical difficulty, right? So I don't know where you lost me, but I will try to recap just very briefly what I was saying, which is that, we don't want you to say yes to an element on the PSP if they are not services that you have staff that are licensed and qualified to deliver. So if you have any questions about that, for the sake of time, I won't go back into it, but you can reach out to me and I'll help walk you through that. We can go to the next slide, please. So now, how is this information shared? Once we get the PSP completed, then, like I said, we load it into an internal database system that Mercy Care uses, and that feeds our provider directory. And then what happens is members, their families, referring providers can get onto the directory and search for those specific services and work to get members connected to those specialty services. It is searchable for anybody with access to the internet. So that is a good way to find who's available on our network for those services. Next slide. So this is a sort of high-level look at what the tool looks like today. And the reason that I asked for us to go through this specifically is because I want to call out a few elements that historically we've had some questions about, and I just want to make sure that folks understand this. So when we list things on here like specific services for ethnicity, specific services for race, specific services for veterans or the LGBTQ population, what we're looking for is yes, only if you have specific services designed to support the unique needs of those members. So for instance, with the LGBTQ population, I wouldn't want you to say yes if it just means that you will accept a member who identifies as LGBTQ, because obviously you should accept all members with with a non-discrimination language in all of your contracts. What I'm looking for is more like, Do you do hormone replacement therapy? Do you do transgender counseling? Do you do body dysmorphia counseling? Those types of things is what would trigger a yes response for the LGBTQ element, for instance. And then what you can do is there's a section in the middle that's labeled response. And if you'd like to, you can expand on what those specific services are so that we're aware and can help make referrals accordingly. Next slide, please. So what are we doing with this? This is the fun part. So as I mentioned, we started sending the PSP out to several different provider groups over the last week or so, and we're expecting that that gets returned to us in about a 30-day turnaround time. I think our first round, we're looking at a return date of actually June 1st. And what will happen is you'll email that back to our Mercy Care Network management email box, which is in the presentation, and we can certainly pop in the chat for you guys as well. And then once we've received all of those by June 1st, we will work to get all of those loaded into our system, and they will become, again, like I said, searchable through our provider directory, and then we will start our next rotation of collecting additional elements. Another thing that I want to mention before I turn it over to the next speaker is we are also using this tool to vet new providers into our network. So not only are we surveying our current network, we are surveying providers who are requesting to join the network to see how the services that they're delivering may be a benefit to our members and help us really diversify the availability of those services. So I think that's all for me. We can go to the next slide, and I appreciate your time. Sorry about the technical difficulties. Thanks.
Thanks, Jessica. It's okay. Like you said, it wouldn't be a webinar. This is our final one. So next we have Adonis, who's going to talk to us about the ACC and RBHA health homes and what they're going to look like for Gila and Pinal.
Hi, good morning, everybody. Thanks for taking the time to be here today. We can go on to the next slide. We can kind of get into it a little bit. So a health home location for members with an SMI designation is really where they receive behavioral health services. So things like case management, their psychiatric appointments, medication management, rehabilitation services. Depending on the type of health home that a specific site is, they can also receive physical health services, which we'll get to in just a second. But really the health home is kind of the hub where members should receive all of their behavioral health services. And if there is a need for services that are not offered through the health home, then the referrals would go through the health home, addressing things like social determinants and so forth. And really that's where all that coordination should originate from is in that health home. So we really have three different types of health homes. So there's the traditional behavioral health home where those services that I just mentioned are offered. A virtual health home is sort of a partnership with a primary care practice. So the behavioral health home in conjunction with a primary care practice would work together on offering integrated services to a member. So there should be an integrated care plan on the primary care side, a health coach, and really working together between those two locations to offer both behavioral and physical health services to a member. And then thirdly, there is the integrated health home where a member can receive both behavioral and physical health services under one roof, really in that integrated approach where they can receive everything under one location. And then we can go to the next slide, where we're going to talk a little bit about the composition of the staff at a health home. So each clinical team should include clinical directors per licensing requirements, and then again per AMPM 570 case managers. Depending on the census, so those health homes that might have a little bit of a larger census would also have a clinical coordinator, which is the lead supervisor for each of the clinical teams. There would also be a BHMP or psychiatrist, RN services available, so injections, health assessment, things of that nature, a rehabilitation specialist, especially given kind of the more rural settings, the rehabilitation specialist could potentially be split amongst locations, but we would, you need to work with Mercy Care the REBA and potentially access on getting that kind of approved and making sure that everything lines up. And then also similarly with the peer support specialist, if that is part of the staff with the health phone, then those should be offered in-house. However, if that isn't available, then there should be, referral out to a peer support service. And next slide. So just a little bit more specifically about the rehabilitation and employment specialists, they really educate the clinical team on the value of meaningful activities in the community. So that could include employment, psychiatric rehabilitation, work incentives, benefits, and really helping to facilitate member connection to employment and rehabilitation services. Really assessing, coordinating, monitoring, and really providing direct supportive and skill-based services in the community setting for members, so not necessarily at the health home, but out there in the community for the member. Promoting RSA and VR program and educating the member to support informed decision-making in terms of the VR program, and then really just coordinating care to assist the member in obtaining and maintaining employment or other meaningful community activities. And next up. So Mercy Care has really 5 levels of care in terms of case management, right? So the Assertive Community Treatment, or ACT, is the highest level of care. It's an evidence-based program really focused on service delivery rather than case management. So right now, about 10% of the membership is assigned to an ACT team. And the ACT teams obviously have a little bit higher frequency of contact for members. So the expectation is at least 4 face-to-face contacts on a weekly basis. Next up is the intensive level of care. Right now, this isn't going to be applicable or rolled out in Pinal or Gila County. However, we are looking at a phased-in approach starting in October of next year, of 2023. Supportive level of care is really where most of our membership resides. It's about 80% of our membership. Face-to-face contact is required every 30 days, and then a home visit is required every 90 days. And then next up is the connective level of care, which is about 10% of the membership. Face-to-face contact should occur every 90 days and then an annual home visit. And then lastly, the 5th level of care is unique to Mercy Care. So there should be 1 outreach attempt per year. And this is really for members that are in need of minimal to no services. So they're well on their way in their recovery journey, but just want to make sure that they're outreached at least annually, just to see if there's any updates or any additional support services that they might need. Moving on. These are just a list of some of the deliverables that are collected either monthly or quarterly. So the case manager monthly report would include caseloads, vacancies from the clinical teams, face-to-face contacts, ISP and assessment completion. Supervisory care home deliverable is monthly. The rehabilitation specialist includes referral to the voc rehab, assessing vocational needs, making sure that there's input on the ISP for the members, as well as learning and working in DB 101 sessions. The credentialed peer and family support specialist is quarterly, listing all of the peer and family support staff at the locations and then which date they were credentialed. And then the COT report is due monthly, which lists all the members who are on COT for that month. And then next slide. And so with SAMHSA Fidelity, we know that this is going to be a gradual shift, might be a bit of a change, but we're looking at making sure that the ACT, permanent supportive housing, supported employment, and consumer operated services are really aligning with SAMHSA Fidelity standards. So really post-October, we're going to be making that gradual shift and push to making sure that SAMHSA Fidelity is met for all 4 of these evidence-based practices. And I believe that was it. Thank you all.
Thank you, Adonis. And next we have Kim, who's going to talk to us about the integrated care management team.
Good morning. My name is Kim Newman. I'm a manager of integrated care management for Mercy Care. You can go to the next slide. So what care management does, and some of our goals, is identifying the top tier high risk and high cost members for the health plan. Those diagnosed with a serious mental illness and who would benefit from care management in an integrated program. What we do is provide care coordination for the members with all of the external providers. And alongside with that, creating a care management plan that identifies all of the members' current gaps in care, struggles in the community, their social determinants of health, any medication compliance or medication concerns, and try and streamline and monitor all of these items. Set up some progress dates and some different outcomes that we're looking for in order to assess the member in the community. What this helps with is reducing some of the hospital admissions and unnecessary ED and crisis utilization, and helping the members have any of the proper tools that they need to manage their care in our community. Next slide. So what our care managers do is do a lot of care coordination assistance with all of the clinics that are out in the community. We do comprehensive case reviews, which includes looking through all of the medical charts, including hospital systems, any of the claims data, consulting with all of the members' care treatment and all of the teams and PCPs, specialists, anybody that we can find that the member is actively seeing in the community. Doing a medication review with all of the health plans and any type of placement review, any open applications, any struggles that are occurring in the community. This information is placed into the care management plan, which I will show you in a couple slides and give you kind of an example of what it looks like. We do attend inpatient and outpatient staffings, currently occurring virtually, but we are going back out into the clinics and we'll start attending those in person. And always act as the Mercy Care liaison between the clinic and the care management staff. And so that way we can assist with anything the clinics need. Next slide. We do have two different care management levels. We have intensive care management, which are licensed BH or licensed RNs, and they work on the members that have the highest risk for medical, inpatient, and ED utilization. They also have an HRA score of 55 or above, may possibly have a history of very difficult discharges, and our highest level of those that are utilizing the inpatient and EDs. Supportive care managers are bachelor level staff that might work on members that have a lot of care coordination needs and maybe just kind of a moderate risk of, medical inpatient, behavioral health inpatient, or ED utilization. Next slide. Next slide again. There you go. This is some examples of what our care management plans look like that we do send out to the providers. We put all of the members' demographics in there for the information we have, and then we do list all of the current providers that member is seeing. That includes the clinical team, PCP, and any external specialist that member is seeing. Next. We do list all of the active diagnosis, which includes medical and behavioral health, and we make sure and verify that all of those diagnoses are current in the EMR. And that way, everyone can see exactly what member is actively being seen for across the board with all of the different providers. Next slide. Interventions and need. In this area of the care management plan, we do put different items that we have found, whether it be a social determinants of health or it could be a certain gap in care. And just kind of coordinate with the clinical team and other providers different items that we are seeing, whether it be some follow-up on medical care from different admissions or follow-up on their behavioral health. Next slide. Education and ROI. We do attach an ROI with any of the members that we are currently working on, so that way we can in order to share different information on the member that we may have from looking in different systems, as well as claims-based. That way, if we do have an ROI, we attempt to put in all of the different providers in here that we know members actively seeing, so that way we can help with really good coordination between all providers. Review and educate the member on, the ROI and the care management plan and all of the integrated health to make sure that the member is receiving everything that they need. And then we can assist if there are different gaps that we have identified. Next slide. So how can our care managers help? There is a lot of information that we can see in our systems that the clinic may not be able to see. So we do help a lot with different assigned PCPs, assist in coordination of care or locating providers that the member has recently seen that the team may not be aware of. Discovering any kind of medical or other medications the member is receiving prescriptions for in the community. Provide the clinical team and members different kinds of educational resources for different medical concerns that they have or medical conditions they have been diagnosed with. Our care managers also help in assisting in locating members who are currently on outreach or the team may not be able to find and are kind of hitting a lot of brick walls in locating the member in the community. We locate inpatient information regarding hospitalizations or ED departments. We send that out on a daily basis regarding members that we see that are inpatient, discharged, or in the ED. And then try to be involved in the treatment plan. We do not share any records that we receive, as we don't share any third-party records, but that's what the care management plans are for, just to kind of summarize what the member is going through in the community. Next slide. That's all I got. Thank you.
Thank you, Kim. Next, we have Laura up to talk about the Office of Individual and Family Affairs.
Thanks, Tara. Hi, everyone. I am the administrator of the Office of Individual and Family Affairs. I have a team of about 4 additional folks, but I first wanted to start just by going into what our office does. And then after that, I'll talk a little bit about deliverables and some of the requirements of some of the services as well. When you hear of the Office of Individual and Family Affairs, it's quite a mouthful, so sometimes you'll hear it as OIFA. It can be used interchangeably, but I like to, speak out the acronyms, just especially with members and families, being mindful of that and understanding that we work in a system full of acronyms. So the OIFA office supports members and families through several different ways. We can help connect the dots in terms of system navigation and help kind of just guide people along through education and understanding the system of what services are available, what supports are available, and kind of where you need to reach out for help. We also assist through advocacy, so we identify any gaps that may be in the system or any improvements that could be made. Also through advocacy, we have internal committees where we have tiers and family members that serve on those committees, and we're also always actively recruiting for those committees. We also oversee the delivery of peer and family support services. And in addition to that, we do some work in the community where we do listening sessions, information sessions, community events, and conferences that help to empower members and give them the tools that they need to take control of their own recovery journeys and and to advocate for themselves. So the mission of OIFA is really the belief that members and families have a choice in the services that they get and have a voice and valuable input to contribute to our system. So if you ever need to reach out to our office for any family member advocacy, I just included my team's email address in the chat, the OIFA team at mercycareaz.org. But that's really the gist of our office. So we really have kind of those two sides of the member and family side where we do those events in the community, but also the oversight and delivery of peer and family support services. So on the next slide, I'm going to go into a little bit of the requirements for that and where you can find it as well. So the big guidance that I would say is the link to the Access Medical Policy Manual. There are 2 specific policies for peer and family support that I included links to as well. But if you actually go to the Medical Policy Manual, you'll see that there's additional attachments. So you can find the deliverable template in there. You can also find some attachments if you're a peer support training agency on an additional deliverable where you would send the list of anybody that you trained to be a credentialed peer support specialist. And also in the Access Medical Policy Manual, you can find the AMP 310B, which is the Covered Services Guide, which also gives you a definition of those peer and family support services. There are quarterly deliverables that are associated with peer and family support. So if you have any credentialed peer and family supports on staff, there is a deliverable that would get delivered to our office. I'd be happy to do any technical assistance if you're not currently submitting it, but it's just a listing of your staff that deliver peer and family support services. And one important thing to note there, if you're delivering peer support, there is a requirement that you have to be credentialed to deliver that service. For family support, just the general S5110 code, you do not have to have a credential, but if you are billing S5110 CG, then that would be a requirement. Narrowing it down just specifically to Mercy Care REBA, we also have additional information that's in our provider manual. I'll talk a little bit about one of the requirements for the advisory councils in the next two slides, but in addition to that, you can also find more information on peer and family support requirements, as well as a little bit later down in the provider manual, it also talks about the continuing education requirements for peer and family support. And that's at 4 hours a year, but that's subject to change. I know right now we're working on updates to the policy. So as that's updated, that information will also be updated within our provider manual. I think I'm ready for the next slide. All right, so as I mentioned earlier, in the provider manual, all health homes are required to have advisory councils. So these are also known as CACs. Some providers call them peer and family councils, but really the mission of that is to hear member and family member perspectives. So really at the provider level, just like we have committees at the Mercy Care level, at the provider level, it's important to make sure that members and family members have a place to go to collaborate and to give ideas for advocacy, improvement, and also ask any questions about services and programming that's available. So if we go to the next slide, we'll just talk a little bit about the specifics of the CACs and just how it needs to be structured. So each CAC is meant to be held monthly for 1 hour. There's supposed to be a chair and a co-chair. Those are member roles. So a member or family member can serve in that role. And then the facilitator and the note taker are meant to be staff roles. So the facilitator is the one that assists with, scheduling the room, sending out reminders that the CAC is taking place, and making sure that clinic leadership is present at the meeting. And then the note taker is responsible for taking the minutes. So what we like to see is the minutes, the sign-in sheets, and the agendas so that we can review and keep in the know of all of the CACs that are happening in our network. And then an additional requirement is that those meeting minutes are also available for members that are at the health home that may not have been able to make the meeting that still are interested in keeping up with the agendas. So I think that's all I have. But again, if you guys have any questions, feel free to reach out to the OIFA team at Mercy Care AZ email, and I will turn it over to Shelley.
So I'm back. Now we're going to talk about court-ordered treatment. Go ahead, Tara. So Mercy Care is already an ACC plan in Pinal and Gila. So we do already have members that are on court order for treatment in those two counties. The change here is that now we're going to be serving the population that's eligible for SMI benefits as well. So most likely the number of folks we have on COT is going to be a little higher than it has been. One of the things that we just want to make sure that you all understand, and if you're already working with us as the ACC plan, you know that we don't submit the letters of intent to treat or the outpatient treatment plans to the court on behalf of the provider. We do rely on you all to do that directly with the county attorney's office or the court. We do expect that if you have someone that's on a court order for treatment, that you do assess annually if there's a need to review that, renew that order. And also requirements in regards to a notice of right for judicial review for people that are on a court order for treatment. We don't have a specific form that we require you all to fill out showing that you've provided that judicial notice of right to judicial review. We just ask that it be documented in the medical record that member has received that notice. There is an outpatient commitment monitoring COT report that we ask for on a monthly basis that covers anybody that was with your agency for even 1 day during that month on a court order for treatment. If you're used to working with Arizona Complete Health, they have a portal where this information is entered. We are still using spreadsheets. So if you need the template for that monthly report, please let me know. We've got a court liaison mailbox that I'm putting into the chat now. So if you have any questions about COT deliverables, what your requirements are under COT, it's outlined in the provider manual, or feel free to reach out to me as well, and I'm happy to come in and speak with you or just answer questions on email. I think we might have one more there, Tara. There we go. And so we do expect that all of our members who are on court order for treatment are assigned to at least a supportive level of care. You know, it could be intensive when that comes out to your area. It could be assertive community treatment, but at least that supportive level of care. If someone's on COT, there's a reason for that, and they need some increased attention and engagement. So it's important that they at least have a case manager assigned, that they be assigned to that supportive level of care. We do expect that there is contact with the case manager and with the behavioral health medical professional at least once a month for everybody who's on COT. If it's over video, that's fine. We understand that there's still a lot of remote work going on, but we do expect to have that monthly contact with both the case manager and the BMHP. So if there's any questions, please let me know. Thank you, Tara.
Thank you very much, Shelley. And next we have Micah to talk about our seclusion and restraint information.
Good morning, I'm Micah Stackhouse. I'm the manager of QM, primarily overseeing the QOC and SNR processes. I don't think you're not going to see necessarily a lot of any changes in the QOC process. You'll still continue to enter IADs into the access portal. You just need to assign it to Mercy Care as the plan. But any seclusion and restraint reports will be needed to be reported to the Mercy Care SNR email address or fax to the 855-244-4908. Other than that, all of our processes should remain the same. Thanks very much, Tara.
Thank you, Micah. And next we have Monica Alonso, who's going to talk to us about our member impact for this expansion.
Hi, thank you, Tara. So there won't be too much member impact. Our members from Gila and Pinal counties will have a new number, as they'll be calling the Mercy Care Member Services number. But if we can move to the next slide, you'll see that some of the other impacts that they'll be seeing, really it's going to be with the name. So this is a cover from our member handbook. And one of the only things that they'll see that's different here is going to say ACC-RBHA on the cover. As usual, the handbook will be available on October 1st. We'll continue to publish it in English and Spanish. And as I mentioned, that cover there should be the only noticeable difference. This line of business will continue to have a separate handbook, so we're not going to roll it into the ACC handbook. If we could go to the next slide, we'll see that one of the other differences, again, on the member ID card that comes in their welcome packet will also reference ACC-RBHA. This card's going to be available by 10/1, and it will be included in their welcome packet. So these are going to be some of the only changes that members across the plan will see. And other than that, the members from Gila and Pinal counties will have a new member services number to call. If you could move to the next slide. One of the things that we're planning for this summer, we're hoping that we can get started in June, is to have some information sessions for the community. So we are looking for providers that are interested in having or maybe co-hosting some of these information sessions with Mercy Care. And really what we're looking for is to bring the members to the virtual screens for these presentations so that we can help inform them on what some of these changes may look like and what that will mean for them.
I wanted to highlight some additional resources we have for you today. This includes our contact numbers for our various departments. This will include member services, grievance and appeals, our OIFA team, claims, disputes and appeals, prior authorization, and utilization management. We have both phone and fax numbers in here as applicable. We also have the fax numbers for physical health and behavioral health admissions and concurrent review for your reference. We also have the resources listed in here, a direct link to our website, to our provider manual. The provider notices, you can sign up for provider notices by clicking on the first link. This will be sent out to you all as well, so you can sign up for them. And if you want to look at any of our previous provider notices we've sent out, those are also housed on our website under for providers and under notices. We also have an entire section for training and education. With that, I want to say thank you very much for all of our attendees today. We really appreciate everything you do for our members every single day, and to all of our presenters for taking time to provide you with all of this content. We look forward to collaborating with you all in the future, and thank you very much for joining us today.